All right, so case study. I'm actually gonna start myself because I think a story does better than words in science. And so basically, take myself now, 41 years old, but I had a pretty significant medical history. Started figuring this out a couple years ago. I did a DEXA scan and found out I basically had the borderline osteoporosis. I'm like, why would I have borderline osteoporosis? I'm like 35. I'm like an recovering endurance athlete. What's going on? And it's like teased it back to my cortisol levels are off there. God, why are my darn old cortisol levels so high? And then I found out, oh, my testosterone's like in the tank. And I also have SIBO and IBS and Candida and hypochlorhydria. And then I did a tick testing on myself and came back with this and was like, whoa, I have 1, 2, 3, 4, 5, 6 different strains of Borrelia, and 3 of them are IgM positive. And I've also got some Babesia and some BART going on too. And I was like, well, this makes a lot of sense. That's why I got shingles in my eye on my honeymoon like 12 years ago, and why I lost 40 pounds that year when I was in residency. It actually made me feel a lot better because I was like, I'm not just stressed out. It's not like a psychological lack of resiliency. I literally have all these infections in my body that are like weighing me down. And so, like I said, I was already doing a lot of cancer testing through the lab and then giving SOTs to other people. And so when I got my titers back, I basically wrote a letter to the lab and I said, requesting an SOT for every single thing that I get a moderate or a high band to. And so they sent me back, I guess it was 1, 2, 3, 4. I think I got 6 off the bat at first. And then there was one, though, that came back negative. They couldn't find it. I don't remember which species it was. They're like, sorry, we can give you 6 out of the 7, but the 7th one we couldn't find, so we're not going to give you an SOT. I was like, okay, thank you. That's, how much? $12,000, worth of therapy. Thank you very much. And so I did the series of SOTs, and then after that, instead of testing myself again through Vibrant, I realized that I get PCR testing for free, which was great. I was like, okay, cool. Well, let me do some PCR testing on myself. And when I did, I found out I had Borrelia turcica in my cells and in my serum, and then I also had Babesia macroti, which interestingly enough, Duncani, which interestingly enough, when I ran on my parents, they had it the exact same Babesia too, in their cells as well. So I found that was interesting. And they were asymptomatic, right? I mean, my mom's had cancer, my dad's, he's got his stuff, but neither one of them has classic Babesia symptoms at all. Which is interesting though. So I'm a big fan, if you can, right? Like even if you're asymptomatic from Lyme or Bartonella or Babesia or EBV or any of these other things, mold, right? These things are still having like at best a low grade strain on our immune systems, and then, they could potentially develop into other things that are much more serious later on. Like every patient with any kind of neurodegenerative disease that I've seen, Parkinson's, ALS, MS, when I test them, like every one of them has really bad Lyme. And or BART and Babesia. And so I'm a big fan. Hey, if you catch something on a PCR, I don't care if you're asymptomatic, treat it, whether it's through herbs or antibiotics or, SOTs if you get the chance. So I went ahead and got a round of these SOTs as well. And so that wrapped up and gave me 10 SOTs. So then I checked myself again, PCR. I was totally clear of everything, which is awesome. So that was me, and that one's obviously the most pertinent in my life. But the first couple SOTs I got really, I herxed a lot on the Borrelia burgdorferi and the Borrelia abszelii. When I got the abszelii SOT, I guess, it was in my gut because it locked up and I couldn't eat for like 2 or 3 days and just had like wicked gas, not trying to give you too much information, but these are things your patients are going to experience, so you're going to be able to counsel them through it. But then after that, my digestion really started to open up and I was able to digest foods better than I had in years. And then maybe I was 8 months into these therapies and all of a sudden I noticed like, oh my God, I just put on 10 pounds of muscle. And then I put on another 10 pounds of muscle. And so I'm 25 pounds up now, believe it or not, from where I was. I'd gone from 180 to 140. And then I couldn't put on a pound of muscle to save my life. Didn't matter how much I ate or, anything. But once I started treating these with SOTs, I was able to bulk up again, which made me feel really good. And then my testosterone went from like 180, which, is like lower than any 90-year-old man I've ever seen, to be totally honest, to actually being high last time I checked it. Just my neuroendocrine system was able to re-regulate by treating the infections, which is cool, right? So some of the indirect benefits of SOTs and other therapies. So this is a gentleman, this actually looks like the guy here, and I actually asked if I could use this case, and he said, sure. He's a friend of mine and a colleague and essentially a functional medicine practitioner too. He does muscular work, a lot of fascial release therapy. He's a manual therapist, but we'll call him LP. He's a 64-year-old male. He has a history of insomnia, PTSD, musculoskeletal pain, nightmares. He had a history of Lyme and Bartonella. And I don't know if he had ever actually officially been diagnosed on testing, but he had been treated for it previously, actually with IV Argentin 23, interestingly enough. And he said it saved his life. But he still had a lot of symptoms. He's got MTHFR mutations, and a lot of his things come from him being in the Hungarian military, and he had a really traumatic experience where he lost his partner, so he's like hyper vigilant during the night, always worried about someone breaking his house, gonna kill his family. So when we checked him, he had a lot of activity too, so a lot of different strains. And with him, he really wanted to go after the Borrelia and the Bartonella. And it was really interesting. So we gave him these 2 SOTs. He got one, and he got, initially when he first got it, I think I talked about it here. Yeah, he felt horrible. His blood pressure actually went up. He had horrible headaches. His arthralgias, his arrhythmias got really, really bad. His headaches, he just couldn't even handle it. And so I said, hey, like what worked for me really well was actually coffee enemas. I don't have any interest in coffee enema companies or anything, but I've just found, especially for people that are like chronically constipated because they have a lot of like enteric nervous system dysfunction from these infections and other things too, right? You got to get this out because there's going to be a major die-off from SOT, so you got to get out of your system. And it's got to be sweat, urine, it could be breathing some at night, right? Respiration, but mainly it's going to be through feces. So if you're not pooping, so I would even say, hey, before you even start the SOT, make sure your patients are having a bowel movement every day, or at worst, at least every other day. But if they're only having a bowel movement once a week, I wouldn't even give someone an SOT. I'd be like, no, let's get your detoxification pathways open first so you can get rid of this. But he started doing coffee enemas, and he had immediate relief, had no trouble after that. And then he started on the liposomal glutathione and a binder. Herxheim reactions totally resolved, and his musculoskeletal pain went down from a 7 to a 2, which I was really excited about. When he got the Bartonella SOT, his herxing was bad, but it was a lot less intense, and all his irregular striae went away, which was really cool. So this is actually interesting. So with some of the Vibrant panels, I like how they compare it previous and post. And I'm showing this one because this is the opposite of what I typically see. What I typically see is you have someone with high bands, you give them an SOT, and the bands come down. Kind of like if we're looking at the IgMs, which is going to be the second category over here, and you look at the P30 band, you see it drop from like a 20.8 to a 10.9. That's what I typically see, okay? Now I'm showing you this one because he had an abnormal case, and I do see this sometimes with patients that are chronically immune suppressed, like using like my sickest patients. If I give them an SOT, I might actually see their immune, basically resiliency or their immune antibody titers actually increase. But it makes sense, right? Immune suppressum is super suppressed, and so they can't even make antibodies because it's an indirect test anyway, right? And so now, because we've given him 2 SOTs, and we've decreased his basically pathogenic load of the Borrelia burgdorferi and the Bartonella, I believe it's Henselae, and his immune resiliency is higher, he's actually making more antibodies. And so y'all have probably, has anyone else seen this in their clinical practice? Doesn't have to be from an SOT, but it could be from herbs or antibiotics. You seen it? Cool. Yeah, so this is really interesting. And so it's kind of like a mycotoxin test where their mycotoxins are a little bit elevated, and then you start basically giving them like glutathione and binders, and you give them sauna, and you check it 4 months later, and then it's like, I've had people's mycophenolic acids and gliotoxins be over 1,000. And they're like, what's happening? I'm like, you're getting rid of it now. And so it's actually a good thing. We're making progress, but it freaks people out, so you have to do some education with that. So I thought that was really, really interesting, and that's how I wanted to highlight this. One of the things, I'm not trying to sell any labs or anything, but I think it is nice to have an antibody titer, whether you do that on the side or if anyone is using Vibrant testing, you can request for any of their infection panels, the tick panels, the virus panels, you can request an immunoglobulin panel for free as an add-on. So if you're using that test anyway, make sure you do that. It's a freebie, and then you know, hey, is my patient starting off with, say, like decreased immunoglobulin G, IgG or IgM levels? Because if it is, I might be getting a false negative, and I have to interpret that, right? Does that make sense to everybody? It's because you have a false negative if they're not making antibodies anyway. So I thought that was just really interesting, so that's why I wanted to show that. This is kind of small here, so I'll have to kind of take a little closer look myself. Okay, and so, yeah, so you see some of his Borrelia burgdorferi went down too, even though we didn't treat for Borrelia burgdorferi, it just got better. Same way with this Turcica. I didn't give him an SOT for Turcica, I gave him an SOT for burgdorferi, but you see that titer dropped as well. Same way with the Afzelli. And so once again, I see this all the time. You don't have to go after every single subspecies. That would be cost inhibitive, right? So I wouldn't necessarily recommend that unless your person's got endless resources. In that case, go for it by all means. And this is the Bartonella, did drop a little bit, which was nice. That's more of an expected. And so after that, we see each other again. So the musculoskeletal pain, the Bartonella, skin striations returned about 3 to 4 months after the Bartonella SOT. And so like Dr. Peterson said, sometimes they have to have more than one. It's not always a one and done. They might need multiples, right? If you do it the second time, it's going to help knock out the residual what's still in there. So his insomnia, PTSD, hypertension were still present. So we gave him a second Borrelia burgdorferi SOT. This is maybe a year afterwards. And then once again, his musculoskeletal pain got better, but then his hypertension started going up again, which is weird because I'd never really seen that with SOTs. I don't know why it would spike your blood pressure, unless it was some kind of cytokine release, your body's under stress, what have you. But still, it just really didn't make sense. And he's really started complaining now about having some just really, really bad gas and bloating. So then, like I said, everything plays together, right? So then we found out, oh, you've got a lot of SIBO. So let's start treating your SIBO. So we started treating the SIBO, gas and bloating got a lot better. But I'm like, there's something going on still. There's something we're missing here. And so then we ran a mycotoxin test on him, and you see he's got multiples that are high, the DHC, the GTX, and the mycophenolic acid. And on this test too, I really like the Mosaic. I really like the real-time labs too. I think they do a really good job. Mosaic's just prettier and more aesthetic, and it's easier for the patient to understand. And there are two different types of testing. So like you can't use glutathione and binders for at least 3 days prior to this. You're going to mess up the test because it'll bind it because it throws off the mass spectrometry. So make sure you get all your patients off of that if you're using like the mass spectrometry test, which is going to be Mosaic and Vibrant. The opposite is if you're using real-time labs, you can actually intentionally give them like a glutathione and provoke it before. But either way, you can do a sauna before. Anyway, so that being said, I always look at these levels in the moderate category, because to me, if these show up, like mycophenolic acid, even though it's not high, that still shouldn't be there. And so I'm like, hey, LP, we got to get your mold under control because you got mold in your house or in your workplace, right? I mean, that's probably the reason why you're not getting better, even though I've given you 3 SOTs, because you've still got so much mold going on in your body. So I think that's like really pertinent. And then the one thing I will say, and this is from talking to, I guess, the director over at Mosaic yesterday, was if the only thing I see elevated on this test is ochratoxin A, almost everybody's got that, and it's ubiquitous in the food chain, so I don't really sweat it too much. If it's 20 or 25 and everything else is clean, I'm like, don't worry about it, maybe take some NAC to help bind it and kick it out of your system, but like I'm not going to treat you with a bunch of antifungals or anything if it's only ochratoxin A. It's just ubiquitous food supply, pass through your body. But any of these other ones, I'm thinking, water damage. And so, yeah, his ochratoxin A was actually even higher though. Like that 62 would raise my alarm bell a little bit. And so with him, right, so we've addressed the gut issues. We've worked directly on his Bartonella and his Borrelia, but the other thing that he's got to do is he's got to really do this limbic system retraining that Dr. Dempsey was talking about. His wife had this really traumatic, basically murder when he was in the military, and now he's just hyper vigilant, so he's waking these nightmares every night. So until we do limbic system retraining with him, and basically teach him that he's safe because he just doesn't feel safe in the world. Okay, like he's never really going to get better, right? Because he's always going to be on high alert. And so this shows like some things like PTSD and some other psychological issues and different areas of the brain that are hypo and hyperactivated. And this neuroanatomical deviations too from the norm go back to obviously the first 7 years of life are the most important with adverse childhood events. But even think in utero, if mom's really stressed out and she's kicking out extra cortisol and that's going to the placenta, that's going to increase the baby's like amygdala on the right side of their brain too, and then make them more sensitive or susceptible to like fear responses, so on and so forth. And then even intergenerational traumas too, right? Because that passes on epigenetic patterns too. And so I think those are all things that we have to really look at. So if you want to maximize to get the best bang out of your buck for your SOTs and help your patients as much as possible, make sure that they're detoxifying. And like I said, if worst comes to worst, just tell them to do a coffee enema. Like they're cheap, they're easy, and they're effective every time. And then you got to address the stress, and then the HPA, TG axis. Obviously, optimizing lifestyle interventions, foundations of health are going to be nutrition, sleep, stress resiliency, physical activity, and then environmental exposures. And then, tests for the co-infections and mycotoxins, which I know everyone here is already doing that. So I've got like 4 minutes and 20 seconds left, so I'll do my Q&A right now. Does anyone have any questions? You can come to the mic or you can just stand up and shout. Okay, I got lady right here first, and then you're next.
Thank you for your talk. It was exceptionally interesting. Thanks. I have a patient with chronic Bartonella that ended up in a wheelchair and required a deep brain stimulator. Is this something that might be beneficial for her?
Great question. And I'm so glad you asked that because I haven't mentioned this yet. So by the time that I have patients that have significant neurological manifestations, this is like the Parkinson's, the Alzheimer's, the multiple sclerosis, the ALS, I honestly think that those are downstream sequelae of these infections and other, obviously physiological allostatic loads on their bodies. But I haven't seen people recover. Even though I test them and I find it, I'm like, oh, you got Parkinson's. Well, look how bad your Lyme is and everything else, right? And they've done some autopsies where they found that, and Lyme in the brain of people with all these neurodegenerative conditions. But I haven't seen them get better. And when I give them SOTs, I'll tell you this real quick because I have time. So I have a gentleman, he's actually a physician that I worked with. He had Parkinson's, right? I gave him his first Borrelia burgdorferi SOT. He was able to write his name legibly for the first time in 3 years and play the violin again. Wow. Couldn't believe it, was so jazzed. I gave him a second SOT. I think it was for Babesia. Couldn't even tell he got the SOT. Didn't even know he got it. Probably felt a little better from the dexamethasone. Gave him a third SOT for Bartonella, and he got significantly worse. Like it got as bad as it was pre-first SOT. And I'm like, whoa, well, that's not good. And he recovered, right? I've seen this happen with the gym with ALS too. I gave him an SOT for Borrelia burgdorferi, and he got worse. It took him about 2 months to recover, and I even split the dose in half for him. And it happened both times on both half doses. And he did recover, and he actually is doing better now than he was when I first saw him. But I think a lot of that's his PT and everything. Okay, so all that being said, now when this gentleman came back a second time, he said, hey, let me do the Borrelia burgdorferi SOT again. I responded so well to that, had another huge gain in function. So jazzed. So then he came back about 6 months later. He said, okay, let me get that a third time. Gave him the exact same pathogen SOT. Third time, he got worse again. So I'm very leery of giving SOTs for people that have advanced neurological conditions. I know they have the infection. What I think, I'm theorizing here and hypothesizing right from what I've seen, I think it causes so much of like a die-off, which is probably causing a lot of oxidative stress in the brain and causing a lot of like inflammation in the brain too. Even if I try to give them like LDN and methylene blue to buffer that, they still don't tend to do well, and I haven't seen them gain function back. So I'm much more like, hey, you've got infection, let's give you the SOT now so you don't get these later on. Once they have it, like your gentleman, I don't think I'd give him an SOT, to be honest. I think I'd go with something else.
I appreciate it. Thank you.
You're welcome. Oh, sorry.
Film busting agents to help, break through some biofilm with the SOT?
A great question. I do sometimes. I like lumbrokinase. I think that one's really effective and really strong, so I'll use that, but I wouldn't use it right after the SOT. I might wait like a month, kind of let the SOT start to clean up, and then basically bust the biofilms open or start to, right, and then release more pathogens so the SOT can go after those too. And like I said, that's more theoretical and anecdotal, but that makes sense to me, so I just don't hit them too hard too fast. Thanks.
I just want to comment on the ALS. There are case reports, as probably everyone knows, where people do recover when treated with antibiotics. And Dr. Martz, who is a famous doctor case of ALS and recovering and going back into practice, he started to treat people with a very, very low dose to start to avoid that incredible inflammation you can get in the brain. And I don't know if there's an SOT equivalent. It doesn't sound like there really is.
I think that's a great idea, and I would do the same thing. I think it's a great idea to treat with, with antibiotics to try to help regain function. Because if they get worse, you can just stop the antibiotic, but you can't stop the SOT once it's in. And then I know there is a doctor down in Florida who I think has kind of become not famous, but she has patients that come to her with ALS and everything, and maybe she has it dialed in. I just don't. So I kind of, do no harm first. But I think that's a great idea.
Quick question, do they use SOT for COVID, for long COVID?
They don't have an SOT for COVID right now. They don't make one. That would be awesome if they did, though.
Thank you very much. I have yesterday I presented how the SOT was working, so I won't go back to that. Yes, I'm working on bacteriophages mainly as part of the research works I'm doing here for this kind of meetings and activities. And I'm also involved in Madrid University for environmental medicine teaching. So we have seen that yesterday. Mainly, it's an endoribonuclease slicing the mRNA and forming some protein, the complex, which enters in the cells and will block the replication of the viruses and also the replication of some cells. That is why it has been used in cancer therapy. When we talk about mRNA, and I was trying to propose to my patients the SOT, it was in the middle of the controversy with the COVID vaccines, which are mRNA based, and I have to explain to the patients that it's a mRNA based therapy, but it's not the same purpose and it's not the same design. The design is not to manufacture a production of proteins like in the vaccine. The idea is to block the replication of a virus. But you have to explain that in plain language, in lay language, something which is very, very complicated, in fact. So there are people that are refusing for these reasons. The problem is for SOT is to have a really key factor, which is an accurate diagnostic. They are very so specific, and that's my explain why my colleagues presented there some failures in the treatment. It could be the key issue. The second key issue is I was surprised to hear about all the die-off effects and all the Alzheimer-like reactions, because normally, as the bacteria do not replicate, or virus do not replicate all in the same moment, we should not be facing a huge destruction at the same moment of the virus or the bacteria. But I do agree that in case of very big neurological issues, this can be, even if there is a long-lasting effect, this could be a problem that can explain maybe the issues which are facing my colleagues with the Bartonella case. This is the case presentation I want to present you. It's a 48 years old female patient with distinct tick exposures, one in 2014, second in May 2016, and a third in June 2016, including joint and muscle pain, fever, chill, myalgic encephalomyelitis, chronic fatigue syndrome, and a cognitive dysfunction called brain fog, and without, of course, the Erythema migrans hallmark. Various diagnostics were conducted using ELISA or Western blot, and they were all negative. There was also diagnostics efforts including Vircell Bartonella indirect immunofluorescence assay, IFA, IgG antibodies against Bartonella and Celia and Bartonella quintana, all negative. We tried to explore a potential autoimmune disorders, and the only results we had was the antibodies, anti-nuclear antibodies test was weakly positive. Additionally, specific antibodies tests were done against nuclear antigens, all these related to what can help for autoimmune disorders diagnostic, and all these tests were negative. Then we have a PCR, phage PCR test, which was positive and confirmed the presence of Borrelia miyamotoi in blood, validated by sequencing, which is very important, whereas the normal PCR in most of the cases are not validated. And of course, it can be a very good tool also. My colleague used the PCR to evaluate the outcome and the progression of the disease after SOT application. I don't know if I looked very well, but I see it was presenting something with 2 amplification cycle difference, which is very, very few, in fact. We could be using a PCR to validate these results, but we should have a better, greater interval. Otherwise, you cannot rely on two cycle amplification cycle difference. CMV positive IgM, which confirmed a viral co-infection. So what we did is to make a measurement of the quality of life, the symptom severity, and the cognitive function through approved scales. I think that's also a very important point if you want to have something which is not only subjective, but with a little bit of objectivity in the following up of the patient. So that was a case presentation. The only thing which is important there is to see that all the tests were negative, and the only ones which were positive with the technique of HPCR and also serology here with a positive IgM for a CMV. So a confirmed viral co-infection and a confirmed presence of Borrelia miyamotoi in the blood validated by sequencing. So he had a treatment using cephalosporin and azithromycin on sequential basis, using this cocktail because it passes the blood-brain barrier, and there are antibiotics which are not, which are a complementary action. Azithromycin is inhibiting complement ceftriaxone by inhibiting the protein synthesis, and ceftriaxone is using another mode of action. So they are complementary. And the SOTs were given 1 month support, starting 60 days after the end of the antibiotics. The 1 month support came from the lab itself in Greece. I asked them, can I give the 2 SOTs at the same time? They said, okay, we have colleagues, or you have colleagues that give it 1 week apart. But the response was, the advice was to give 1 month apart. So to maybe not for safety reason, but to discriminate which was acting in fact. I think so. So I followed their recommendations, and we did like that. This, and also the antibiotics, also treatments, and for supplementary vitamins, mineral, and detoxifiers, and also some diet. Well, Borrelia miyamotoi, when I had that patient with the chills and the muscle head aches, I was thinking it could be a certain form of babesia, I was thinking, or maybe this kind of relapsing fever. And I was right. And this underlines the importance that we have to do to the clinical symptoms. I guess if I've been facing, like for the other patient, a multiple infection, even if it's by antibodies, which is not quite a reliable test, and also, above all, if it's IgG, even in high levels, well, the decision to decide what would be the first SOT, in my opinion, should be based on what is the main clinical issue. And even if we know that the clinical symptoms overlap in all these diseases, there are some ones that are indicative of a direction and of a pre-selection, if I may say so. So that's all I have. I have about 75 cases of SOT treatment. It's not a big experience. Now you know that in Europe it stopped because of some legal issues, and for the European Drug Agency is conducting an inquiry after some problems which have been appeared in some northern countries of Europe, and then so we cannot get it. So my experience stopped 1 year ago, and I really appreciate your presentation because you're the only one that can continue and to gain this experience. What I think, however, that the main important results were observed, in my experience, with viral infections. And it makes sense because we have very few treatments for viral infection, in fact. So this is a big tool. So if I had to continue, and I hope I will continue, I will make reserve that preferentially for viral treatments. That's all I have to say, and I'm happy to answer to some questions if you have. Thank you very much.
I wanted to present a case that had a lot of different levels to it, the MCAS portion, the infection portion, some other things thrown in because I think this is not an atypical case, and it even ties in some of the stuff that I talked about yesterday. So this is an 18-year-old female who presented in 2018 when she was 12 years old with recurrent fevers, severe fatigue, leg pain, joint pain and cracking, insomnia, brain fog, nausea, intermittent sore throats, and anxiety. Her early history, I always do a history from as early as possible. She had her mother had a normal pregnancy. She was delivered vaginally. She was breastfed for a year. And she was always healthy, actually. The mother commented that her other kids actually seemed to be sick all the time, and she actually didn't catch the normal stuff. I think that's sometimes important to note. And then she was pretty much well until around age 9 or 10, when she had an acute onset of anxiety and panic attacks that were out of character for her. And then after several months of sort of searching for answers, she was brought in to see me. And we did sort of the normal stuff. There wasn't anything really crazy initially, but vector-borne testing was a little bit, kind of borderline. She had a Lyme Western blot that was indeterminate, but she did have band 31 and 41. She had elevated anaplasma, but it was again like 80, and you need, to be over 160 to be active. Bartonella, Hensley, IgG was also kind of borderline. FISH was negative. And this is back in 2018. So, I think our testing has gotten so much better, but I was sort of limited with what I could do at that time. But it was suspicious enough. It was borderline, but suspicious enough for me, given her risk factors, living in an endemic area of the country, plus other exposures. So I did opt to treat, and we did, back then, really, there weren't a lot of options in 2018, so we did some antibiotics. And, we rotated some things, we tried some things, and basically 6 to 9 months of treatment, she was pretty well. And she felt she was really back to baseline. The mother thought she was back to baseline. And so 2 years later, she goes to sleepaway camp in New England, which is another endemic area. And she comes home, and by the time school starts, she starts getting sore throats, low-grade fevers, and fatigue lasting, sort of 7 to 10 days, and then it would resolve. And, she was strep tested, they did all the stuff. And this is unusual because this is somebody who up until now really hasn't been sick a lot. And so she gets sick and then resolves, and this goes back and forth a few times. And by March of 2018, she gets the same set of symptoms, and now just basically can't come out of it. So the anxiety returns. She has now more nausea, and joint pain, joint cracking, and the need to crack the joints. The feeling of joint swelling, even though there was not any obvious joint swelling, was notable. We did additional testing, and the only thing that actually came back positive was a tick-borne relapsing fever, IgM, which I think is relevant, of course. She was pale, lethargic. She did have some mildly tender bilateral lymphadenopathy. She had some erythema of the pharynx, even though all the testing was negative. She had mild dermatographism, which I do use to test, all my patients, which is basically a scratch test. And she was pretty hypermobile in her knees, elbows, thumbs, and her 5th digit. And so she did meet the Beighton criteria. I did have a slide on that yesterday for hypermobility syndrome. And then, that basically alerted me to the fact that she probably has underlying mast cell activation syndrome. So we started the workup, and she had repeatedly elevated histamine, plasma histamine, and mildly elevated chromogranin A. So we started, the H1, H2 blockers. We trialed a few other things she didn't do well with. And then we started some antibiotics. So we really struggled with the antibiotics. With tick-borne relapsing fever, my go-to was Doxy first. Sometimes she had reactions, and sometimes it was more that nothing really was touching her. And so during that early first few weeks or months of that illness, she really became very obviously orthostatic, and we did confirm POTS in the office. And listen, not all the patients need tilt table tests, okay? You can diagnose POTS in your office. I believe it is that really pervasive, and so you should just really be testing. And so I use either the 10-minute Nassau lean test, or I do orthostatic measurements, supine, sitting, standing, depending on the patient. And I find both those tools really, really helpful. And if you don't know the Nassau lean test, you can look it up. Dr. Cindy Bateman, I think it was the one who sort of put that together, and maybe on her website, but it's NASA, N-A-S-A. But we were very aggressive with the POTS, with fluid, with compression, with salt, and it would help a little bit, but not enough. And during this time, her increased joint pain and joint instability was treated with a physical therapist who was experienced with. We're lucky in our area; we have a few physical therapists who do have experience with hypermobility. I sent her to a neurologist who wanted to do small fiber biopsies, and she did have some antibodies on the early Sjogren's test, and her EMG nerve conduction study did show early chronic inflammatory demyelinating polyneuropathy, or CIDP. And so she was approved for IVIG, and we were hopeful that maybe she had an autoimmune type POTS, and maybe with everything that's going on with infections, she needed additional immune support. We continued to try various other antimicrobials. So she sort of like would get a little better, get a little worse. It sort of went on back and forth, but she was reluctant to take antibiotics. So I really had to find other ways to treat her. And in 2020, she started developing increasing headaches and pressure in the head. We did an MRI that showed sort of like a large cisterna magna or an arachnoid cyst. We have a really amazing Atlas orthogonal chiropractor in the area who was able to diagnose her with basically craniocervical instability and basically a C01 misalignment in the cervical vertebrae, which he believed was compressing the CSF fluid and was basically causing increased intracranial pressure, which was then exacerbating her symptoms. And it could be that maybe her reaction to doxy and some of the other things we were seeing was actually causing increased intracranial pressure as well. But there was definitely a structural problem. And so she started going for some adjustments, and she started to notice when the symptoms went up, she would feel something that didn't feel right in the neck. She would go to the chiropractor, and he would adjust her. So it did help, definitely helped the headaches, but she was still fatigued, had insomnia, lots of joint cracking, and difficulty getting through the day. She really started having more heat intolerance, flushing, and erythromelalgia. But again, like I said, brain fog and headaches definitely were better. And now I have more testing available to me, more reliable testing, and she is now FISH positive for Bartonella Hensley, and an IgG positive for Vinsoni, and Western blot IgG positive for Borrelia burgdorferi. We talked about, so she was probably an early case for me. I think I started doing SOTs in like 2018, 2019, but I was also sort of like reserving it for like the worst cases. But at this point we were like, okay, let's start talking SOTs, and I really worked on her mast cells, as I mentioned earlier. Like I really think that's a really important preventative measure. And so she was on H1H2, but we trialed ketotifen, we trialed cromolyn, we trialed LDN, and I'll tell you anecdotally, I have maybe 20% of patients who do not do well with low-dose naltrexone, no matter how low I go. She's one of them. It actually made her anxiety worse, even at 0.1 milligrams a day. We trialed Benadryl. We increased her H1H2 blockers. She tried, we do an IV MCAS drip in the office, which we tried, and which actually helped her periodically. It's a combination of famotidine, Benadryl, Zofran, and then we started with the Borrelia burgdorferi SOT. That does tend to be, I think Dr. Bell also mentioned that he sometimes starts with Lyme. I think it depends on the patient, and it's really like which one is the most positive. But at that time, I definitely would have started with Lyme and then sort of gone down the line with the other co-infections. But the plan was to do Borrelia burgdorferi, then Bartonella Hensley, and then Bartonella Vinsoni. And she tolerated the Borrelia really well, but did have significant Herxheimer reactions after each of the Bartonella. And significant, but we got her through it. Somebody mentioned Berber Panella. We're doing lots of detox support. We're doing more H1H2. And what I would say it was typical for her was that day 3 was sort of like when things would kick up till day 7. Not everybody's like this, but this was sort of what we saw with the Bartonella ones was day 3 to 7. and then sort of drop down. And then a couple weeks would go by and she would, while the SOT is still working, you might see a flare again. And that's the challenge with SOTs because they're in the body working, for potentially 4 to 6 months. And so there can be times when things are a little quieter and then the SOT starts working again, the bugs are out, and then you'll see a little bit of a flare. So she is much better. There is some notable changes, but not where she needs to be. So we do testing. This time we did some fibrin testing. She had Borrelia mayoni, Borrelia turicate, and I believe because the tick-borne relapsing fever was positive after that sleepaway camp experience, that was probably her tick-borne relapse. They couldn't identify the strain. So in this case, we found Borrelia turicate, which I think was relevant, and then Bartonella Hensley was positive again. So we decided to do a second Bartonella Hensley. We did decide to give her actually extra IV Benadryl prior to the SOTs, and we started doing this with a few patients. That actually, it seems to, even though it's short acting, it seems to like carry over a little bit, and they, patients seem to do a little better. And she starts to have more energy and stamina. Still hard to get through the day in school, but, and there's still insomnia. She still has a little bit of intermittent constipation and nausea, and the flushing and heat intolerance is still present. So she and her mother, we sort of had this conversation. The mother wanted to be a little more aggressive. The daughter was sort of finally on board. And she decided she really wanted to try antibiotics now. And I think what happened was she was feeling more confident that she was actually getting through some of this and she was feeling better. And maybe she was like, okay, I don't know if she was concerned that the SOTs wouldn't be enough. So we did do the double dose dapsone protocol with her and with a 6-day quad dose dapsone. And then a month later, she did the pulse. She only made it 4 days though, because the pulse, she is interesting. She did okay. She was blue by the end, but she did okay for the first part of it. But that second pulse really put her over the edge. And she said, I think I'm done. I just got to recover. And she did recover, took a while. I don't know if anyone's done the double dose dapsone protocol, but it does take some time to recover the bone marrow and other things. But what she noticed remained, and actually Dr. Horowitz, sort of alludes to this, that sometimes there's some residual stuff, whether it's BARD, whether it's Babesia, that the dapsone's not getting fully. So she still has heat intolerance, she has flushing, she has a little more pronounced erythromelalgia in her fingers, combined with Raynaud's and fatigue. And so we said, okay, you did the dapsone, maybe that lowered the load. Maybe now we're really dealing with, less bugs, which I think is what's happening with a lot of these patients is that, where the goal is like lower the bugs, help the immune system, right? So we did some additional SOTs. She did test positive, fish positive for Babesia coli. She tested positive on the Vibrant for Borrelia turicate again, and the numbers were still high. So I did a second one for that. We did a second Bartonella vinsoni. We did a second, and then eventually, over time, like 6 months or a year later, we did Babesia coli, or not 6, yeah, it's like 6 months later. And so where she is right now is she's off IVIG for probably close to a year. POTS is controlled, MCAS is controlled. She's only on H1, H2s. And what she found was that the additional SOTs, definitely led to more increased stamina, exercise tolerance, decreased brain fog, and increased functional capacity. I'll repeat her stuff again in 3 or 4 months, kind of see where we are. I wouldn't be surprised if she might need another round. She is positive for EBV, so I probably will go in and maybe look at the viruses with her, depending on what symptoms are left. So I think that's it for this case. I have like 3 minutes left or whatever, if you want to ask any questions. Thank you. Can you get up to the mic? Thank you.
Thank you, Dr. Dempsey, for this interesting case. I just wonder, over 5-6 years of treatment and all this testing and supplementation and treatment, how much does it cost roughly?
It's a good question. Yeah. I couldn't give you a number. There's no question it's costly, right? So that's why I've changed how I do things. And I presented this case to show you that, I'm human. I would do things, I learn, right? And that's one of the things that I pride myself on, that there's a better way, I'm gonna find it, right? So in 2018, I did things different than I would now. I probably would have started her in SOTs right away. So the hope is actually to get the patients through treatment faster so that the SOT itself is not cheap, it's expensive, but if you put the investment in early and you're doing the support that they need and cleaning, things out and making sure that they're not living in mold and, all the other stuff that I didn't mention here, but, there is always other stuff, hopefully in the long run, they save money. That would be my goal. Yes.
Well, this is kind of question and not question.
Okay.
So in trying to proceed from the most aggressive treatment of the most aggressive organism to less aggressive organisms, there's that point where you have to decide what's the end of Babesia.
Yeah.
And I was going to suggest that there's a pattern of recovery that starts in heat, excessive heat, sweating, then moves back to just flushing, and then it moves back to I'm cold all the time. Yeah. Especially if you're not going to do adequate herbal support with, and the vitamins and deal with microbiome. But that is the nocturnal process. Then you see the second place, the same pattern imposed during daytime hours, so that the query of Babesia doesn't stop until you've met with a quiet night and a day that's cold. That's the step that puts you over into BART management. And if you're waiting for BART management, that's your impatient golfers heading to the surgeon to get their fusion. Because they're like, this neck pain is insurmountable. I just treat it for 6 months. I'm done. It must be time for surgery. When in fact, if you can hold them down for Bartonella with something like Dapsone, you're not asking a question. You're telling them, we're now ready to proceed with Bartonella because we've managed Babesia completely. Well, the only way you get to the end of that pattern is you move through a nocturnal, asking them, is this where you are? Then letting them go through the daytime. At that point, that is the point where you transition into, you can have now access to hyperbarics at depths that are like manageable for Lyme. And so a depth beyond just doing your detox. You won't accomplish that in a multi-chamber or with the soft HBOT. You won't. So everything before that is detox. Okay, that's like HBOT. But with this, that would be a good point to introduce this SOT therapy, because you're dealing with you've gone from the one that is aggressive and you're dealing with the one that's persistent and annoying. And I think these gentler therapies where you're not poisoning the system with antibiotics are very helpful and synergistic. I just wanted to make that little point. Okay. I was wondering about what you put on your slide about the autoimmune conditions. You're checking them. Do you use SOT to manage them? When they test we had the labs, all these different autoimmunes clarify their status. Do you ever use SOT for that?
Well, there's no SOT for autoimmunity. Right?
Just the
They're
infectious.
just for pathogens,
Okay.
right? Or cancer. Yeah.
Oh, well, okay. So
Yeah,
if those autoimmune states, you do a cancer evaluation and that comes back positive?
No, it's not cancer. Yeah. So, okay, so let's say they have positive antibodies, right?
Let's say they're mastocytosis. That way we're agreeing it's something.
Oh, mastocytosis.
Yeah.
I don't think we have a SOT for, I don't know if we can do SOT for mastocytosis. Do you know? Right, so the question was about mastocytosis, and you can find, if you find the tumor, then you could potentially do an SOT for it. So cancer, yes, but there are brain cancers you can't use. for, and pathogens, various viruses, bacteria, but not for an I don't know how you would target SOT for autoimmune. Were you here for my talk yesterday? Because I think a lot of the autoimmune stuff we're seeing, these autoimmune markers, are really not autoimmune diseases. I think they're part of the process of the immune system being dysfunctional, some of it driven by mast cell activation. Who's next? Yeah.
I'm just wondering, in terms of your case study, any changes with the hypermobility and the EDS symptoms after the treatment?
Yeah, she definitely has, the joint pain went away completely. She's still hypermobile. We didn't get rid of the hypermobility, but much more stable. She was just constantly feeling like her joints were unstable. And yes, at this point in time, other than seeing that she's hypermobile, her symptoms are much improved, which is in line with some of the other papers out there. There's a paper that Dr. Mosiani published about the resolution of EDS after treatment with Bartonella. I think that's really, really unusual, but clearly the infections are exacerbating it. Yeah.
Thank you so much for the very detailed case. I have a question regarding the strategy around whether we're treating quote unquote co-infections prior to Borrelia or treating Borrelia first with SOT. And I know that might be patient dependent, but I spoke with Dr. Terry Beim of our GCC sort of at length about Borrelia absaliae causing, and I guess a number of providers are also seeing Borrelia absaliae cause sort of a setback or regression in people's cases. And she used specifically a case example of a patient with Parkinson's where they had been treating for some time and made significant improvements, and then did a Borrelia absaliae SOT that really set him back. And then they've been subsequently having a lot of trouble getting back to where they were prior to that one. So I was wondering if you or any of the other providers that have been using SOTs for some time have seen that, and would you potentially, if there is evidence of Borrelia absaliae in the case, if you would treat that first to sort of mess them up as much as you can and then get better, or how would you do that with absaliae?
Honestly, I'm not sure it's specific to absaliae. I've seen that happen with other microbes. Like I've seen that happen with Bartonella. I've seen it happen with Babesia and various strains. So I'm not sure it's just the absaliae, and we'll see, what Dr. Peterson thinks. I have not seen that specifically for that strain, but I've certainly seen that phenomena a lot. And I think that there are a couple of things that I think about. I think about the immune dysfunction related to that infection. Again, so were the mast cells not well controlled? Is there something else that they're also being exposed to? Is there mold now in their house and that they didn't have before for the last SOT that they did? I think there are other factors that you have to take into account. And I think that sometimes it's very difficult to predict which is the thing that's really like going to set them off, right? So if this person had such a severe reaction to absaliae, is it because it's the load from it? Is it because of all these other things, right? You don't know. But it's interesting that they said the same thing to that particular organism. I've seen it with all of them actually. And it's a little bit disheartening, and a lot of patients get, really concerned, like, I just undid everything. And sometimes what we'll do is we'll go in with some herbs, or we'll go in with antibiotics sometimes, right, and just settle it down. And sometimes what we find, I will tell you, the other thing I see sometimes is that we do the SOT, let's just say it's absaliae in this case, right? And all of a sudden they're flaring. And if you go through their history, actually the symptoms they're having are a flare of their Babesia. And so I've just knocked down some load, and now Babesia is out. And so now I know that I actually have to treat their Babesia more aggressively, right? So this is like the art of medicine, right? I'm not saying it's like this all the time, but it makes me wonder if it's lowering the load, but actually letting other bugs sort of come out.
Okay.
Does that make sense?
Yeah, and then similarly, I've had better results with treating Bartonella first with SOT before going towards Borrelia, theoretically, potentially due to the rapid multiplication. And actually in myself, we did Borrelia first and then Bartonella, and I think I had Bartonella problems. And so I've been, as a rule, if somebody has evidence of both Borrelia, Bartonella, trying to do Bartonella SOT first to avoid any big problems. But then, especially with patients with limited resources, if I really suspect Bartonella, but their Bartonella test is negative, for example, on Vibrant, do you have any suggestions around provoking what other tests to pursue, or whether to just move forward with the Borrelia SOT and just keep a really close eye on Bartonella and then add on the SOT when you get a positive test, or how would you go about that?
So, we've been talking a lot about Vibrant testing, or you could say IGeneX. The antibody testing it's not perfect. It is useful in figuring out some SOTs, but I don't think it's the best test. I'm going to be honest. I hope they're not in the room. I don't think it's the best test for really detecting active infection. So the only way to detect active infection, in my opinion, is to do TLAB. And you do TLAB, and then it still could be negative, and then you do the Borrelia SOT, and then you repeat TLAB, Bartonella, and see whether it starts it may be sequestering somewhere in the body. That's the thing about Bartonella, it does that. And so I don't think you need to provoke it necessarily, but treating something else will sometimes provoke it to come out, But I think you need fish testing. But typically before I go down the SOT route, I'm sort of proving. And I guess you could also use the RGCC testing, Biocenter and all that stuff to do their PCR testing. I typically start with TLAB, I see what's active, and then I'll fill in the gaps with the antibody testing.
Okay. Thank you.
Yep.
Did for on that case study, did you retest in 2024 any of those pathogens? And for the Ota coli, did you do any antiparasitics alongside the SOT, or was it just SOT based? And if you did a retest, were you able to eradicate it with just SOT?
Yeah, so actually, I just drew it a few weeks ago, and I was hoping I would have the results for the time, but I didn't have it back. I did just retest. So yeah, we did. Yeah, my style is a little bit of okay, here we're going to do the SOT. Let's see where you are. Let's give it a few weeks. If the patient is really symptomatic and still not able to function, I might go in and do some antiparasitics, and then I might get them ready for another SOT. So it's like a little dance. I tell the patients that's my style. Some other practitioners will just be like, let's just get all the SOTs in, and then we'll figure it out. But yeah, I did do quite a bit of anti-parasitic, anti-malarial stuff with her, sort of pulsed. So yes, too bad I don't have the recent results, but she's doing pretty well. So my guess is that hopefully things will be, not visible, but if they are, we know what we need to do.
Perfect. Thanks.
Thank you. Maybe the last one, right? Yeah.
Thank you for answering my T-cell testing question. So I'm going to ask a different question. I've had an ALS patient with me for a number of years. I'm in the middle of Alaska. I don't have a lot of resources, unfortunately. I'm convinced that he's done so well leaving Alaska for SOT because we aggressively treated mold, Lyme, and heavy metals prior to, and I really believe with all my heart that he's going to reverse. To save all of my Alaskan patients, do you know if training is available to nurse practitioners?
I don't see why not, but
Okay,
Yeah.
excellent. Do I have time for a really quick mast cell question?
Does she have time for a mast cell question? Yeah.
Okay, so I tend to see probably most of the EDS patients in Alaska. I'm on the list. And when I have the trifecta that I can't get quiet, I had the pleasure of meeting Dr. Luke Liu.
Oh,
And
great.
I have noticed that if they're that hot and I can't treat their mold, I can't treat their Lyme, I'll send them for a stellate ganglion block.
Yeah, yeah.
And I've noticed that I've become utilizing that a lot more. How long would you wait with traditional mast cell support, doing all of the things to quiet them down before you say, hey, let's try a block?
It's interesting because this is something, I've been learning more about stellate ganglion blocks, and I had the pleasure of seeing him speak at a mast cell conference back in September. And so I think after his talk, I was thinking, I think maybe I need to send more patients for stellate ganglion blocks. So, this is sort of the new kind of world, right? We're trying to treat, he treats a lot of long COVID.
Yes.
And so I think that's why this treatment is becoming more popular. So it's a good question. I think from what I'm learning, I think maybe that is something that can be initiated maybe a little bit sooner instead of waiting till they are so bad and then too reactive, right? But I think it's a balance. I don't know if I can tell you, it's wait 1 month or 2 months or whatever. I think it's all clinical. But I'm excited about that as a tool potentially. But I also think you also have to think about other structural issues. So I think the stellate ganglion, from what I understand, I'm certainly not the expert, but it is going to help the parasympathetic nervous system and decrease the sympathetic, right? I mean,
Yes.
that's kind of
Yes.
how it works. But I look at that as it's a procedure. It's like dealing with sort of structural things. A lot of these patients, not a lot, some of these patients have compression syndromes like pelvic congestion that Dr. Cutchins talked about yesterday. They're going to be patients who have that are making their mast cells disease worse, or they have median arcuate ligament syndrome or SMA syndrome, or they have so those are like compression. These are all compression, or they have such bad craniocervical instability.
Yes.
So I guess it's you look at the whole picture. You try to understand where you intervene. I don't want everyone getting surgery, right? But it seems like, there's going to be a subset that a procedure is going to get them out of the flare, and there's some that, just some really good mast cell support is going to get them better,
Right.
or an SOT, right?
Right.
But I think it's exciting, yeah.
It is exciting. I was actually speaking with him the other day, and he's now doing some studies on celiac plexus blocks for the severe constipation in Ehlers-Danlos patients. So that's another coming. I don't know. All that stuff excites me because I have nothing in Alaska.
Right.
Anyway, thank you so much.
Yeah, you're welcome. Thank you. Thank you all.
I have 2 cases. Of course, I cherry-picked ones where I was successful, right, because I want to look like a winner. This first case I highlight because I think sometimes we believe that good enough is good enough, and it shouldn't be up to us, right? Personally, I'm fairly conservative. I would say professionally, outwardly, I'm a libertarian. We should let people make their own decisions, and I sort of struggled with that with this patient. A 44-year-old woman had been in excellent health, that's what she presented as, said, I've been in excellent health, right? She runs these half marathons a few times a year. She plays volleyball once or twice a week. She's got 4 kids. They're, somewhere between young teenage and older adolescent, and she's busy, right? But she comes in complaining about anxiety, depression, lack of motivation, and some fatigue. But really what brought her to me is she wanted to lose weight, right? Her weight was the most important thing. And then these other things I sort of had to tease out of her. And I think that this is, maybe I'm just bad at taking histories, but I had to tease other things out of her as we went. So that was the first, complaint. She also admitted that she had this sloshing stomach that some previous physician had diagnosed as runner's gut, which I'd never heard of. But she said that she felt that way since living in Taiwan for a year as a young adult. So that was, in her 20s. Now, 24 years later, she still has this sloshing feeling when she does her half marathons. She had some brain fog. She rated her fatigue as a 3 out of 10. But she still got up and did all the stuff that you do when you're the mom of 4 and enjoy being active and exercising. She did have night sweats and insomnia. And so I have a program called GDRX, Gut Detox and Rehab. Dr. Shilpa Saxena is in the same group as I am, and she, sort of coined that. And it's some different shakes and some detox, and she worked with our coach, and she did those things, an elimination diet, and she was real consistent, and everything got better. Energy went from a 3 to a 7 after 6 weeks. Sleep, mood, brain fog, all improved. She was feeling really good, right? But this was her second visit, and because of some of the symptoms that she reported, I do a fairly, like probably all of you, very extensive lab panel. And she had a very low CD57. And she also had 2 bands for Lyme on the Western blot. And we ordered a Vibrant test. I don't think it's the best test by any means. I'd like to call it the Honda Accord of Lyme testing. It's relatively inexpensive and it can do a lot of things, but you can't haul a boat with it and you're not going to win any races with it. She was found to have 5 antibodies for Lyme, but she was also found to have toxoplasmosis and 1 other form of Borrelia. So more discussion at the second visit. She's feeling good, but I'm just, well, how much, are we ready yet for this weight loss thing? And she said that a year before she'd been in Mexico and lots of mosquito bites, and ever since that, she had these night sweats and headaches. And at the first visit, she didn't even mention the headaches. I think maybe she mentioned them more at this second visit because that hadn't changed at all. Her sleep and her mood and her brain fog had improved, but these headaches were still a thing, right? So here's her Vibrant testing. And you can see oh, here we go. All right. She's got some antibodies, right? But she also has this Bartonella quintana and Borrelia mayoni. And quite honestly, I don't know. I don't know if this is worse because that's 21 or if this is worse because there's, 4 different antibodies, 2 are IgM and 3 are IgG. I don't know. But that was her test. And we started her on Daraprim for the Toxoplasma gondii, Daraprim, leucovorin, and some naltrexone. And after a month, the night sweats were totally resolved, and she was now having headaches only once a week. Normally, she would have headaches every day, is what she said. Sleep had actually improved even more. Now her gut, she says, feels normal since the first time since college before she went to Taiwan. No more sloshing. BMs are formed, and she's having 1 or 2 poops a day, right? So, and I'm like, okay, you're better. And she says, no, I thought you said there was this thing we could do so I could get all the way better, and I've got these infections. And I'm like, well, yeah, I mean, you can, but that's expensive. And she said, well, I'm coming to you so that you'll get me better, not so you'll tell me what things cost, right? And I think we have to check ourselves about saying, hey, this is expensive. Well, it's expensive to be sick. It's also expensive to eat healthy food. It's expensive to go on vacation. And so she was actually a little bit offended that I would tell her that it's expensive. She's like, don't tell me that. Just tell me when I can do it, right? I don't care what it costs. And she's not overly wealthy, right? So we did these 2 SOTs. We did the Bartonella and the Borrelia mayoni. And we talked about that we could do all 3, but maybe we just do 1 of the Lyme and then see what happens, right? And I also put her on transfer factor and Immuno-G, which they're both different colostrum products, and then Thanabiotic. Now, I like Dr. Hazan a lot, but she says this doesn't work. I have a theory for why it works, but that actually made I think, meaningful difference, especially in this patient. Anyway, now symptoms totally resolved. She's running her half marathons again. She's sleeping 8 hours a night. She feels great. Headaches are totally gone now, not even once a week. She used to have pain in her knee after her races. Now, right, she's 20 years older than when she started running these races, no pain in her knee. So your arthritis in your knee at 44 isn't because you're 44. It's because you got inflammation in your knee, right? What's causing the inflammation in your knee? Not being 44, right? It's something that's causing that inflammation. She feels bright mentally, her mood's good. And I liked this and I was always nervous of her husband because he just had this sort of quiet, like judgmental look all the time. He'd come in and she'd do all the talking and he'd sit there with his arms folded like, you're gonna screw this up. You're not very smart. Why are we here? And so I was a little bit worried. I just was afraid of him. And at the last visit, he was still the same. Like his demeanor was still the same. It was like we were in a business negotiation, just sort of that feeling. But right at the end, when they stand up to go, he breaks into this big smile and he shakes my hand and he says, Dr. Peterson, this is the girl that I married 20 years ago. I'm old now compared to her. And he's now a patient, not because he has Lyme. And she didn't come in because she had Lyme, right? She came in because there was something wrong with her gut. But we can help people get all the way healthy, right? No matter what's wrong with them, if we look at all the things that can make them sick, we can probably figure it out. So that's the first case. Now Liz, it says that she's 46. She's 46 now. I think when she came to see me, if I'm doing the math right, she would have been like 39 or 38 when she first came to see me in September of 2017. And she came in and was more of a classic. she's coming to my office because she thinks she has Lyme disease, right? And I'm known to treat Lyme disease. And she complains of severe fatigue and muscle loss and exertional fatigue and headaches and lymph node swelling and neck pain and muscle pain and brain fog and poor cognitive function and all this stuff. She's got pain in her shins and knees and hips, her back, her neck, her shoulders. She gets this pins and needles in her arms and fingers. And it's worse when there's a full moon. And she brought that up to me. I don't always ask. I do think there's relevance in it, but she was the one that, told me. And that's because she'd been seeing another functional doctor. And so she's like, I think I have Lyme, and I think I have some parasites, and maybe it's Bartonella. And so it had taken about 8 years for her symptoms to slowly get worse and worse and worse. This is interesting to me that her symptoms became dramatically worse after her hysterectomy in May of 2016. I have a theory that that's where Bartonella likes to live, but it's just my theory. So after her hysterectomy, she began to have GI issues, diarrhea, GI pain. She'd done lots of cleanses and supplements with another doc and an elimination diet, and nothing really made any difference for her. She'd just slowly been getting worse and worse. So these were her initial tests, and there's lots of other tests, but those are some of the ones that were salient. You can see that we did a bunch of tests that insurance doesn't cover, like the mycotoxin. That was probably through Great Plains when that was their name, and a Marcon's or an O test, and ILADS does a IgG food sensitivity and a heavy metals test, and DNA connections and prime spot were how we first looked at her Lyme. And anyway, so here's her first lab, the iSpot, which was positive. And it only looked for Lyme, of course. Here's her mycotoxin test. She also did a VCS test because that's cheap, and she failed that. We did the VCS test first and then followed up with the mycotoxin test. And here's some gut labs and her, food sensitivity, and there's her metals. And so we started treating her for Lyme. She'd never been treated for Lyme before, just her gut, with diets and things. And I gave her Tindamax and Doxy, and then we switched it to clindamycin and Plaquenil. I just sort of went through the chart, because it's been many years, and tried to pull out everything we've done over the course of these many years. So those are sort of a variety of things, and some of them are herbal, like you can see AL Complex, A-Mike, those are from Byron White. Once disulfiram was a thing, that made really significant impact, so I'll sort of walk through this. Each time we would do antibiotics, it would have a positive impact. And then her GI symptoms would get a little worse, and sometimes she'd have neuropathy, and that wasn't just with the disulfiram either. But overall, positive effect. And then we're like, okay, how long can I leave you on this before I need to switch it? Herbals, she did pretty well on the herbals. She didn't have too much of a die-off reaction, but as soon as she'd decrease them, the benefits would stop. And there were lots of stops and starts to her progression because, I took care of her, or have taken care of her for so long. I think disulfiram, of all of the antibiotics that she was on, was the most impactful. That was her report to me. And she really felt quite good after disulfiram, but after about 6 months, her pain and fatigue returned. And I know she got COVID, and that seemed to cause her symptoms to return. And then she actually just recently got COVID again. But it was after the disulfiram that she got COVID, and then a lot of symptoms showed back up. And we couldn't go higher than 300 milligrams on her, which was pretty close to her dose based on 4 milligrams per kilogram dosing anyway. I think she was supposed to go up to like 350 or 360, but if we went higher than 300, she'd have lots of depression and neuropathy. So for her gut, I like Ion Gut Restore. You can't get CME because I just said a brand. Izyme, Biocide, and Diflucan, and Nystatin. And her gut would improve. I think that probably the antibiotics and killing some of these infections was why it was improving with the supplements I was giving her as opposed to previously before she was being treated for the infections. This sort of goes back to that framework that I pointed out. Like, I really don't think people get better unless you take care of how do we support their ability to recover. And so, with appropriate testing, she's on NP thyroid and testosterone cream and progesterone. And Adrenal Complete's just an adrenal glandular with some adaptogenic herbs. And initially, she had lots of breast tenderness and sort of excess estrogen metabolite issues. And so spironolactone and anastrozole were initially needed. Lugol solution made a big difference for a lot of her breast tenderness because, uterine and breast tissue is iodine hungry, and so that actually made it so that we didn't have to give her as much of the anastrozole and spironolactone. And DIM sort of does the same thing. So this is also an early win too, right? You start these people on these supportive things and they start to feel somewhat better. And she could sleep a little better. She didn't hurt as much, right? And so it just makes it easier to go through the whole rest of the course of treating her chronic infections and her toxins. Like I mentioned, she had these on and off breast tenderness problems, especially when we were doing the mold detoxification things. So she still uses now testosterone cream, estrogen cream, oral progesterone, and MP thyroid. And the sort of detoxification, excess estrogen issues are now resolved. And we did do chelation for heavy metals. Okay, so I just labeled this immune and sympathetic therapies. Low-dose naltrexone, low-dose immunotherapy, if any of you guys know the work of Ty Vincent, that was quite helpful for some of the viral things early on. Some of these anti-inflammatory, turmeric, black seed. Early on, Provigil and phentermine were quite helpful to her. I think that we have to treat patients' symptoms as we go, because otherwise they just can't tolerate it. And I think that boost was helpful. Synapsin, that can be compounded. That helped her brain early on. I didn't put it in here, but I know she's been on oxytocin at times because that's helped her mood as well. And then magnesium threonate was helpful for her sleep. So I sort of back up here as I'm describing each of these different antibiotics. The very first thing she did, she went from having no energy to being able to be active until about 1. And then body aches sort of got better, but they show up later in the day is all. She did early in the course back in 2017, 18. This thumb pain was a huge issue. Every time she'd come in, she'd want me to focus on her thumb. And I don't know, maybe that's where a lot of the nidus of infection was. I have no idea, but it eventually has resolved. She was really concerned about her face after just the very first antibiotics. She got some steroid cream from her sister, which I probably wouldn't have encouraged, but it seemed like it helped her. And so then we changed her to a different antibiotic, and pain sort of continued to improve. Fatigue got worse. That's when she decided to do this low-dose immunotherapy. It helped, but it was tricky to find the right dose for her. And I think that has a lot to do. My experience with immunotherapy is if the patient has a whole bunch of problems, their immune system is so upset at so many things, it's hard to find the right dose of their low-dose immunotherapy. I tend to use it now towards the end of the process rather than at the beginning. Doing it at the beginning is helpful because it's easier to find the dose if it's a simple issue, but if it's really complex, then they get frustrated, and then maybe you can't get them to go back and do immunotherapy again later when you still need to calm down their immune system. It is homeopathic though, so it's totally crazy and probably doesn't work, right? Wink. So she stopped that and she started to do IV ozone, and that helped some. And we had her on binders, and that's when she started to have the breast tenderness, and we talked about the anastrozole. And I probably should have, at this point, started her on a thing called calcium D-glucarate and Femguard, which is some chaste tree and some... Anyway, I didn't because I wasn't smart enough back then. The ozone was helpful. Detoxification was helpful. Binders, butyrate, phosphatidylcholine, Duo Detox. I was using Quicksilver Detox at the time. All of those things seemed to help. I actually didn't put it in these slides, but one of the things that she found dramatically helpful as we got towards the end was the comprehensive protocol from Cellcore, if you guys are familiar with that. I think that probably made a difference in the probably parasites that she was a host for, just like these other things. So eventually in 2020, when I started to do SOT, and she was one of the early patients, we did this through BioCentaur, and she was positive for Borrelia mayoni, and she was also positive for herpes type 1, and this TEC-116S is sort of like hey, you have some sort of a tick-borne thing, but we're not sure what it is. Because she was positive for the Borrelia mayoni, you can potentially make the assumption that this is the cause of that. That's not always the case. I do not use BioCentaur's lab very often because, unlike Dr. Bell, I don't think it's as sensitive just because it's PCR, and that doesn't, I mean, if it's super sensitive, it's also noise. So I see a lot of these that are negative, and it's $1,000 or something like that per test. And so I just don't use it as much as I'd like. But the theory is, if you get this, you could just send that to the lab and say, hey, she's positive for some sort of a tick-borne thing, make an SOT. And whether that tick-borne thing is Babesia or Lyme or Bartonella, they're going to put in appropriate primers and do it. But the real limitation to SOT is our testing accurate? And do the primers that they chose, did they give you the right oligonucleotide, right? Or was it just noise? And so I have had patients that I've done SOT for, and one of the various ones that we did nothing for them. And I don't know if that's because it was, noise or what, I don't know. So after the first SOT, really just occasional pain in her arms and neck. She would go down to Dr. Calzada in Mexico and get stem cell injections every 3 or 4 months, and that would help her pain for 2 to 3 months. After the SOT, that was the Tech C SOT, and then the number. Oh, actually, we did 3 for her. So she did that one, and then she did the Borrelia mayoni. Initially, I had chest pain and elbow pain, and that sort of resolved after 2 months. And what I've found with SOT is everybody herxes differently. It is for my very sickest patients, because that's where I started with SOT. They couldn't tolerate anything. And you're like, well, I don't know, you can stay in your bed and have seizures, or we could try this new thing. It's the only other new thing I got. And so I had a few courageous, very debilitated patients, and they certainly had far less Herxheimer reaction than they had with when we said, okay, I'm going to give you microdose disulfiram, or I'm going to try you again on doxycycline. So I do think you have less Herxheimer reaction with SOT, and that's just, it makes sense. It's sort of instead of like shooting people to kill people, we're just putting birth control in the water to kill people, right? Instead of shooting the bugs, we're just putting birth control in the water. So, it's sort of a slower, protracted. Don't put that on the recording. So then, initially, RGCC required that you use their lab, or at least that's what I understood. Then when I found out I could use different tests, I started using Vibrant. And this was around the time that I started using Vibrant. I still don't love them, but they're very effective for this particular modality because they look at so many different strains. So by no means do I think it's the best test. It's just the one that makes the most sense if this is what you're going to do. And she was positive for Borrelia burgdorferi, Borrelia afzelii, bavariensis, Babesia microti, Bartonella henselae, Vinsonii, Quintana, and Anaplasma. So now we did an SOT for Borrelia burgdorferi and Borrelia afzelii, and after 4 months, the pain was nearly resolved and energy had improved again. And like I say, she sort of waxed and waned through this whole process. Feeling meaningfully better. She said that actually changed things in a way that no other treatments had. And she couldn't really put her finger on it, but she was like, I just feel I feel improved in a different way. And I don't know what that was about, but she feels better in a different way, and hopefully that means it sticks a little longer. Let's see. All right, more mild. And it doesn't wax and wane anymore. It's like, okay, now whatever pain I have is just sort of constantly there, but it's not as severe. Then we did Bartonella Vinsonii, and to one of these doctors' points over here, I would do Bartonella Vinsonii first now. Helped her mood, headaches went away. I've done Bartonella SOT for my wife, and the biggest difference it made is she's not as dizzy and she doesn't have headaches anymore every day. This one was interesting, and it makes sense to me. She had bruising all over when she did the Bartonella Vinsonii SOT, and I think that's just because Bartonella likes those little capillaries, and so she got really pronounced bruising, and the fatigue took another step up. Then she did SOT for Epstein-Barr. That seemed to make the biggest difference for her brain fog, but it only lasted about 3 months. Then we had to do the SOT for Epstein-Barr again. She did SOT for HHV1. That also had some impact on her brain fog and her fatigue, which surprised me because it's supposed to be in her mouth, not her brain. And I've seen that multiple times where herpes type 1 and herpes type 2 will improve brain fog. So she's done each of the SOTs for the viruses 3 times. Here you can see her initial labs and then some improvement, and some things resolved, like the Borrelia afzelii went from 20 to nothing, and these just went down. And do we do it again? I don't think so, because antibodies are lagging indicators. We could check again in a year. As long as she doesn't have symptoms, why spend the money on the test? She actually didn't agree with that, and so she continued to test until everything. Now this was everything. Oh, no, we're not quite there yet. Until everything was completely resolved in 10 of 2023. So let's see. There you got previous and current. So what does she have? One antibody for Borrelia burgdorferi. Let's see. Okay, yeah. So she treated. She continued to test until she said, good, I want to see everything gone. Now, this goes back to why I, sort of put my lecture together the way I did. She saw benefit from every intervention we employed, right? Antibiotics helped, IV ozone helped, herbs helped, SOT helped. Detoxification was, I think, a critical step for her. Hormone and thyroid was important. Gut health, you can't build a house without a foundation. She did get COVID in December of 23. She also got COVID again in just a very mild case in August of this summer. In 2023, we put her on naltrexone and ivermectin and Nagella sativa and quercetin, et cetera. And it took a little while, but she got better. And then I had given this presentation 6 weeks ago. She actually has improved. We just did the same thing, and she's improved again, right? So if she hadn't, maybe I would have added Maraviroc because that's what we learned, right? I've had lots of other cases. Like I said, I cherry-picked these two because they worked. So anyway, any questions? All right. Oh.
Just slow, sorry. I just wondered, do you ever use EBU ozone or IVIG around SOT on purpose? Do you ever kind of use other IVs or other things to help get a better result?
Yeah, that's a good question. I don't. Let's see, the answer is yes. I don't know that. I'm just sort of feeling my way through it, probably like you, Casey. I think one of the big problems that we face with SOT is that there's so many opinions out there, and I think it's Facebook page driven, right? And so the patient will come in and say, I was on this, and I heard that that's going to make it not work, and now that's the problem. And I think Dr. Bell describing why it's a good idea to not be on antibiotics right at the beginning of the process is important, because you've got all this DNA that could just sort of use up some of the SOT molecules. But if somebody, does SOT, and we also give them IV ozone, and it helps their mitochondrial function, might it kill some of the infection? Yeah, I think it might. Is that going to make the SOT not work well? No, it's not. The only one that it makes any physiologic sense to me, and I don't think anybody knows, because I talked to Dr. Papasaterio, who runs the lab, and he's like, well, no, we made these guidelines because they make sense. Well, a lot of things make sense, and then we, test them scientifically, and it wasn't accurate, right? So they haven't tested to see if we shouldn't be giving antibiotics or ozone around SOT. It just makes sense, right? And so there was a period of time where I would, have a package of ozone once a week after four weeks out from the SOT. I think those patients do well. It's a question of, is that financially worthwhile to them? Because my experience is they do improve faster. And I don't, but because there's so much just sort of chatter out there, then you get this reputation of, oh, but he didn't follow the rules. The guidelines said don't do this, and so that's what you're up against.
Two questions. One, what do you recommend in terms of the minimum amount of time between SOTs? And then secondly, do you recommend biofilm busting before or after the SOT, Lucumbrize or, nattokinase?
Yeah, I do think doing biofilm therapy before and during is super reasonable. I will give, and this is the rules according to RGCC, and you got to follow their rules, which is fair. You can give an SOT as frequently as every week. I tell patients that if they're going to fly into Utah to get them done, well, you can fly in and we'll do one on, Monday, and then we'll do one the next Monday, and then you only have to fly here once. But I don't recommend it. I think you probably should You're going to know by next Monday if it's a good idea or not. Because if they're having a lot of Herxheimer reaction, I don't think it's a great idea to say, okay, let's kill two things at once, right? So it's up to the patient. My typical cadence is actually every 2 to 3 weeks. It sounds like a lot of the other doctors that presented are doing it every month. I just leave it up to the patient. I say, look, you could do it as often as next week, but I'd recommend you wait 2 weeks and then reassess. And they can come in. It doesn't take long, right? The infusion takes 40 minutes, and so there's no reason in my office where they have to schedule some appointment. We're not that busy, so they just call and say, hey, can I come today? And the answer is yes, as long as the phlebotomist isn't out, right? So that's how I do the cadence. Did that answer all the questions?
That's great.
Okay, my question is, I've had patients that are doing a lot better. They're like 95% better, symptoms are gone, and they want to get retested. And then they continue to test positive. Is there a period of time that you recommend to get retested? And if they continue to test positive, do you continue treating?
That's a good question. Like I said, I'm a libertarian with respect to my patients. I think we're too paternalistic. So if I were to tell someone, no, you can't be retested, that would be silly, right? But I try to explain to them and say, look, the objective is to get you all the way well, whatever that means. I don't think that we're going to be, mathematically, it is very unlikely that we get something to go to zero, right? That's why they invented calculus, because getting to zero is hard. But getting to zero isn't really the goal. And so we're in this paradigm, this mindset of we have to kill all the bugs. Well, that's absurd. If you killed all the bugs, you'd be dead too, right? And so I think if you have those sorts of conversations with your patients and say, look, what we're trying to do is we're trying to make it so these pathologic microbes are gone to the point that either you can't detect them or it doesn't matter that you can detect them, right? Dr. Dempsey was talking about low-dose or heparin and how we do this heparin test and we can't find it. Well, we know the body makes heparin, but we can't find it. Well, that should tell us something about our negative Lyme tests. Well, we can't find it. We probably should still assume it's there. So if the patient wants to be retested, yes, I will retest them. I have generally seen that the tests correlate with the symptoms with bacteria. With viruses, that is not the case. I always treat the viral infections last because it's been my belief, and I think my experience matches my belief, but I'm not certain, that if you treat their bacterial problems, their immune system can handle their viral problems. Now, that's not always the case, but that's why I figure, well, these are expensive. Why don't you treat the bacteria first? This isn't your question, I don't think, but it's been shocking to me when somebody has a really low antibody level for a particular bacteria. Because I'm sort of looking at the big three, Bartonella, Babesia, and Borrelia, and they could have an antibody level on a Vibrant of 11. And if I don't do it, because I'm like, oh, that's low, don't worry about it, they're not going to get all the way better. If I just go in order, Bartonella, then Babesia, then Borrelia, they just do much, much better. So I don't think that the antibody levels on the Vibrant actually tell me a whole lot. I think it's more the groups that they're in. And then with Lyme, there'll always be, generally, not always, but 2 or 3 or 4 different kinds of Borrelia. I'll probably just treat the worst one unless there's 2 of them that are, both of them really high, and one's tick-borne relapsing fever family and one's Lyme family. Then I'll treat both of those. But when I repeat their labs, if they had 5 or 6 kinds of Lyme, I treat them for 2 of them, and I get the results back. And the 2 that we treated have gone down, and the 4 that we didn't treat, that were all pretty close to normal anywhere, are gone. Right? So, not your question, but I don't think we have to test until it's gone because I don't know that it will ever be gone. That's my opinion.
Thank you.
Crystal.
So what I was thinking when you were talking was that patient that keeps coming back positive, looking at the dyad of exposure so that without spending another dime on SOT or Lyme treatment, you're saying, it's time to look at your husband or your wife and see what they're carrying, because that's going to be a lot less cheaper than to take the $4,000 and completely treat the partner, especially if he's a knucklehead. He's got a great immune system. It doesn't take as long to treat him.
Right.
And she's not just swallowing and swallowing and swallowing while he's sitting there going, she's the sick one.
Right.
But actually, he's the carrier state that keeps reinfecting. And so he's protected. and he isn't as much at risk as the female patient with the autoimmunity risk?
No, I think that's a great point. And I think that how much we pass something back and forth sexually has to do with what are our loads in our vasculature, right? If it's in your blood, well, then you maybe, if it's in my knee, it's not going to get somewhere else through my semen, right? It's in my knee. But treating someone's partner is a good idea. And the fact that our immune systems work is why we're not sick, right? And so it's not necessarily a negative thing to have a positive antibody. It depends on, are you symptomatic as a result? And I think that's a great place to look is, maybe you keep picking this up in low enough amounts that it's still positive even if you feel okay. Because that knucklehead husband, he feels fine the whole time and he had it the whole time. So it's not about did you get rid of it, it's about did you get it low enough and then get the immune system behaving properly and now you're healthy. So. All right, well thank you.